Thank you. My name is Nadeem, and I've been addicted to quality improvement for 4 years and 7 months. I thought Friday afternoon there'd be 12 lonely souls. There are a lot of us around, aren't they, this afternoon? I wanted to just start by telling you a story about one ward, really, bring it down to day-to-day work. I know this slide doesn't come through very well, I apologize. I'm going to talk about a failed ward or a failing ward that became an exemplar ward, actually a ward that people came to learn from, achieving culture change within months, using quality improvement as a management method. To put the ward in context, I work in one of the biggest hospitals in the country, and within it is a very large pediatric service. It has all the secondary and tertiary services you could imagine, many wards, many beds, the full range. And in that facility, a particular ward that the matron was very worried about, particularly worried about the quality and safety of care on that ward, but also about the staff. This is a surgical ward. I'm not a surgeon. It's a surgical ward which over 3 years had lots of trouble, traditional management approach applied, leaving the ward with quite a disciplinary culture, high sickness rate, and poor morale. And the matron asked me, after I'd come back from my sabbatical, to see if there was anything I could do to get a better understanding of what needed that would make a difference. I need to tell you what I didn't do, because fundamentally I'm a full-time clinician. I have a busy hospital practice. I didn't do any classroom teaching. I didn't take anybody away on an away day. I certainly didn't talk theory, although I learnt a lot. I didn't use any expert language. I didn't demand any graphs. I didn't because I couldn't spend any money, and I certainly didn't sack anybody. I didn't sell a method or even develop a method. And I didn't start this project, which became a project, by measuring the culture of the ward that I was asked to look at. And I think it's interesting to note that by accident rather than by design, I did not involve any managers or executives in this particular piece of work. And I think that's worth a discussion in itself, particularly that one chief executive in the room. So let's talk about what I did do. The first thing I recognized that I had to do was to redefine leadership in terms of the work that needed to be done. The ward was actually being managed, if you like, remotely as well, by emails, with edicts imploring all sorts of changes. I think you'll be familiar with that particular approach of management. And I decided that actually what was really needed on this ward was a very explicit joint medical and nursing leadership, because quality isn't a nursing responsibility or a medical responsibility. It's a combined medical and nursing responsibility, and leadership with a purpose, which was a quality improvement purpose. And I learned in the first few weeks of my engagement with a senior nurse on that ward that I actually had to do quite a piece of work of undoing her traditional management thinking before I was going to get a chance to begin to apply some of the stuff that I'd learned during my secondment. The second thing that I did, and I think this is quite critical, is be very explicit in terms of what I said and how I behaved in recognizing every single member of staff as an equal professional, because we all do work of equal value, so therefore we must be professionals of equal value. And my theory that it's not my theory, the theory that I applied is the theory described by Elliot Friedson, a great thinker on things on professions and professionalism. And there are three things that define a profession: being highly certified, having autonomy, and some sense of self-direction. And I knew that what I had to allow was some sort of autonomy within the staff, and I needed to support their thirst for direction, because I certainly didn't have any at that point. The other thing that I began to realize as I was walking the environment and learning about the environment with the senior nurse was that it struck me that it was a bit like the theory of broken windows described by Wilson and Kelling in the 1980s. You may be familiar with it. It was the theory that actually transformed policing significantly, firstly in New York. If you see a community with lots of broken windows, graffiti, and litter on the ground, you know it's a neglected environment, people are disengaged, and there is policing by catastrophe, because that environment allows the assault and the murder to take place. Now, this ward wasn't covered in graffiti and full of litter, but certainly in terms of the work, the engagement, the data, I got a sense of lots of broken windows with disengaged staff, and really definitely policing by catastrophe when a major error took place on the ward. And of course I used measures and understand how many broken windows and how much graffiti was in the system. I looked at drug error rates and other measures, which I'll come back to in a moment, but I used these measures as a proxy of what became a sense of a very poor culture on the ward. Now you'll be familiar with a ward facility. It has all these bits in it. And I put these pictures up simply to show that I was going into this facility at any moment I had during my working day, even in the evenings, 20 minutes, 40 minutes, whatever time I could find, to go and look at the ward, observe the ward, and even measure what I could in terms of the flow of work and the interaction between staff, patients, and so on. And I looked at every aspect and every resource on that ward over time. And I knew that I had to have a quick win if I was going to be able to engage the staff. So that was part of my purpose. And I realized there was a chance for a quick win when I looked at the dispensing room facility on that ward, which was actually a shared facility between doctors and nurses. You'll see a trolley in that picture on the left, which is a resource used by doctors for accessing bloods and cannulation for patients. And I realized that actually by observing that, there was a phenomenal clash of flows and an immense amount of disruption of work, both for nurses and doctors. And I asked the nursing staff on that one shift whether I could take that resource out, put it somewhere else completely differently, and then put this notice up that you may not be able to see that asked for the door to be shut. And therefore this facility suddenly just became for the nurses. And I didn't design a project, I didn't build a team, I simply spoke to the nursing staff on that shift and the second shift and said, let's try this, I have no idea whether it'll work. All I want to know is what you feel like when we've used it, and then we can change it back after 2 or 3 shifts. And I came back after the 3rd shift, and to a woman, and all the nurses on this ward are women, said, there's no way they're going to get that trolley back in again because they now feel safer. So I had a quick win, and that was actually a fantastic start to a little bit of work that was going to be a lot of work. Now we're all familiar with this idea of managing resources in wards, because that's where work is done fundamentally, a lot of the work. And of course here we have a picture of the resource facility, which is the inventory room or the stock room. And it looked exactly like this, with boxes also standing outside the door because it was so full. And I watched this facility in use, and I found out who was in charge of it. And I was interested to understand what people felt about its use. Now, I'm going to introduce you to Sharon, who is in charge of this facility on that ward. She's a healthcare assistant, and I was absolutely clear that I wasn't going to tell her what to do or how to do it. I was just going to first understand what she understood her job to be. So let me introduce you to Sharon, and she'll tell you very briefly how she changed her view, or what changed in her view.
Previously, I thought my job as a healthcare assistant was cleaning, stocking, tidying. I was then challenged by Nadeem and realised that my job is actually all about patient safety.
So Sharon was in charge of this facility. Once she began to understand that everything she did was of equal value and actually fundamentally linked to patient safety, was then actually able to do some work that we wanted to do, which was about measuring the use of that stockroom. And I never at any point used the word lean in the entire project, not once. I simply asked them how they thought they might want to change the use of that particular resource in the context of patient safety. And without asking not once for data, I said, why don't you go and measure something, choose one thing that's expensive and used a lot, and then we'll have a look and see what the data looks like. And without me requesting it, they sent me graphs into my inbox a few weeks later. I didn't ask for graphs, they sent me graphs, and they started measuring more than one thing. The result of this, the detail doesn't really matter, was they discovered there was, of course, and you all know this, over-ordering of stock relative to what was needed. We built a safety system to make sure that we didn't under-order in the end, had a facility that looked like that, and not once did I use the word lean. And they've sustained this, and the real outcome for this is that ward, in the work that it's done so far, has saved nearly £60,000. That's a real saving on that ward's budget in terms of resources being requested. We have not used anybody from the trust management or the procurement system or the person that stocks to do any of this work. The people that do the work, know the work, have improved the work. Let's talk about drug errors briefly. So drug errors are interesting because the error rate, certainly in my organization, is much higher than the actual true error rate. In one study that I did with my colleague, we showed that the error rate reporting was 1/16th into the trust system of the real error rate, not all of it reaching to harm. And this surgical ward was no different. The error rate, when I observed it, or actually and prospectively as well as looked at retrospective data, was at its worst, sometimes 2 to 3 times a week, 3 to 4 times a week. And this graph, which is not an SPC chart, because I've kept it very simple, particularly when I'm in the initial work I did with the staff, showed that the higher the graph, i.e. on that graph, the better the outcome, the greater the interval between drug errors. And we did a number of projects over time, and what I'm just going to show you is a summary of the outcome of a number of projects, not all related to drug errors, because I think it's a number of things that we did that affected the overall functioning and capability of the ward. We ended up with an interval of 89 days between drug errors. Remember, a ward that was having about 3 to 4 a week. And then we reached 113 days, and so on. What was fascinating about this was, when the first error occurred at 89 days, the matron, Gail Conn, phoned me up, absolutely distraught. I mean, absolutely distraught that the record was broken. The nurse involved with the drug error on the night shift fell sick. She actually called in sick because she was scared about the disciplinary outcome of being involved in that error. When I was told about the error, I was excited. And the senior nurse thought I'd gone mad. I rushed to the ward excited because for once we were finally able to quickly unpick the error, because there were fewer broken windows distracting that system, and therefore we were able to put in a test of change to improve it. This is a ward, I don't know if you can see this, is now actually writing the story of the error. That nurse eventually wrote the story of that error, and then started counting, the ward started counting again and reached 113 days. Another error, another story, and then another count. This is a ward that was measuring nothing, and I mean nothing. And now not only is it measuring it, but telling the story and displaying it for everybody to learn. So we moved a ward from external behavior of investigate, interrogate, and discipline to a self-leadership within the ward to analyze, listen, and learn. I'm always intrigued when I walk into a ward as to whether I can immediately tell that the ward is actually interested in quality improvement and measuring. It's pretty universal. Well, it's not universal. It's becoming more common. But this ward wasn't doing it, and this is what they started doing. They defined quality using the Institute of Medicine definition, how they were going to do the improvement, and in the red on the side here, the projects they were doing. But as is the way of organizations, they thought this was a good idea, and they wanted all the wards to do it, but they wanted corporate colors, and they wanted the measurements they wanted on the wards, hand washing, etc. So we lost that board. They wanted that board for corporate data. Never mind. So they went away and took away 2 other boards and built them again to continue to tell the story for all the world to see that we're on the ward. And you can see at the bottom, they're even displaying the intervals between drug errors at the bottom of that white chart. So just to give you some data, I think the nurse manager has become a QI thinker from a traditional management perspective to a QI thinker. I think there are a number of staff, if not most of them now, are coming to not only do the work, but to improve the work. We moved a ward from fear of errors to actually telling the story and writing the story, and a healthcare system that doesn't just do stuff, but actually does patient safety. And if you want numbers against that, then we went from quite a high drug error rate to the graph I've already shown you, from a ward that was doing no improvement projects to 6 active at any one time. And absolutely brilliant work by the senior nurse. When I asked her, can we allocate time to the nurses doing these projects? And she said, yes, just like that. So she said 30 minutes for any nurse that's doing an improvement project in her shift, and I'll cover that work. An improved sickness rate. And by accident, rather than design, the matron became a not-so-secret shopper of the ward. Her son was admitted for a surgical procedure. She became a mother of a patient, and she, at the end of it, was delighted with the experience, at the end of about a year of work. But it's not my story. So let's just listen to Nicola, to Michelle, who talks about another project we did on the ward, improving the safety briefing.
Yes, after the PDSA cycles were introduced, the handover time was reduced from 45 minutes to an hour to 20 minutes. And this just totally reduced our handover times. It highlighted the importance of who was at risk, who was poorly. And this it gave us half an hour a day to spend more time with our patients.
So extra time with patients from a really straightforward project. And Nicola?
A year ago, it felt unsafe and I felt like my licence was at risk at times. Now I feel a lot safer and my licence feels more secure.
So, just to summarise, I could argue that what I did when I first went onto the ward was to really get to understand the environment, using the theory of broken windows, if you like. I used measures as a proxy to understand the culture. I engaged the staff using a joint leadership, medical nursing, and theory of professions, and then I brought learning back into the system through testing. But actually, to be very honest, all I really did was apply Deming. That's all I did. Resiliently, without letting go, every day that I was on the ward, and I achieved culture change with the staff within months. So I'd like to say thanks to the IHI Improvement Programme, which I was part of, the Managing Hospital Operations Programme, and of course to W. Edwards Deming. And I'm also available for weddings and funerals.
Thank you, Nadeem, Michelle, Sarah, Nicola. Any question to Nadeem? First of all, let me see if he's real. Are you real? Yes, he is.
I'm a doctor. Isn't that shocking?
Wow. So, any question? Yes, please.
I'm Abida Owan. I'm a clinical scientist from Manchester Royal Infirmary. Nadeem, I wanted to say that you're quite a senior member of staff, and so people are going to engage and listen to you. I've been equally addicted to quality improvement, but again, to get people to listen to me, even though I'm head of service, has been quite difficult, and to overturn a culture. So where there have been issues of clinical governance in a ward, and I've made, highlighted a few things to the clinical directors, it's pretty much, well, that's not your concern, you're head of lab. So I think it's that kind of culture. Where do you go to, get someone senior on board who's going to support you to make those changes?
I think that one of the key things about this piece of work was, if I'd gone in as a manager, I don't think that would have worked. Because I had some clinical background and credibility, but I'm not a surgeon. It's not my environment at all. I don't have patients routinely on that ward. I think you need to find somebody that works in that facility, that is a medic, that sees the problems, understands the problems, and is prepared to work in joint partnership with the senior nurse, also responsible for the ward. I think we sort of delegate that responsibility of quality in the ward facility to a nurse. And I think that's unfair. I think we're all responsible for quality, and that's why I felt that joint leadership was actually the way to begin to show that we were all interested, and therefore the work was enabled that way. I'm not sure that answers your question fully. Clinical directors have got so many other pressures on them, mostly to do with saving money, that unfortunately this sort of stuff falls right down to the bottom.
Any other question? Yes, one more, and then we have also some from the tweets.
Okay. Doctor, Diana Rodriguez Hurtado, Lima, Peru, Open School. What about the professionals that work at emergency department, at room of surgery, surgeons and anesthesiologists, and who work at ICU? Do they need special and different care in order they don't fall in burnout syndrome? What do you think?
So, this is a question about whether different types of specialties or care environments have a different requirement for quality improvement. Is that the question?
Because when we think that we need to work together, when we think that we have the interaction in the personal must be better, but all the professionals of health don't work in the same place. Some professionals work in more dangerous place, inclusive some professionals can get occupational disease. And what about if I work in TBC program and maybe I got TBC? I feel the same that the other professional. I feel I will be involved in quality and safety in healthcare, like the other professional that didn't get a disease, occupational disease.
I'm not sure I can actually really answer that question. I think that's more to do with how the organisation manages its environments to keep staff safe, I suppose. And I think that's a different aspect of organisational governance and safety.
Okay. If you don't mind now, you can join all the speakers that we have some questions from tweets.
Okay, so we have some questions here. The first one is from Maxim Craig, and it's from somebody who would like to hear more about using psychodynamic theory to help teams in difficulty.
I think we recruited in 2006 we recruited an organisational psychotherapist to work in my team, and we began to look at the psychodynamic models that we all live with. We looked at things like the natural position of the drama triangle in teams. We looked at adult parent-child models. We use a variety of family therapy models to help teams look at their own dynamic, and we're just there to facilitate that. But we've learned that actually shining a different light on the way people behave towards each other helps us look at the way they behave in terms of delivering care. So that's been really fascinating, working alongside an organisational psychotherapist.
Thank you very much. And the second question is for Christine Pabico, and it's about when practitioners focus on a particular issue, results tend to improve.
Yes.
But the question is, how do we sustain these changes in the long term?
I think the continuous improvement of engaging the staff is what's going to help that, because once you have that environment where they feel like, they can openly talk about things, bring up any concerns, that's the thing that's going to, sustain that kind of environment and outcomes.
Great, thank you very much.
Thank you. Any other last question? No. May I kindly ask you a question? Would you mind please exchanging with the person next to you what you are going to do, or if you have any experience or a suggestion for tomorrow, what are you going to change or to do or to think for tomorrow, using all that, but especially your experience. And moreover, before leaving the room, please be so kind to shake hands and exchange energy, because we talk about teams, but we are person and we are teams. We have to really connect and be aware that we are together. So we need to really make this happen. So if you don't mind to exchange a last word, what you are doing and perhaps sharing. Thank you very much. And thank you very much to our speakers.